Hi, my name is David Doig. I'm a neuroradiology consultant with UCLH NHS Trust, and I work out of the National Hospital at Queen Square. This is Module 2, Lecture 2 of the BSNR's educational programme, and we're going to be talking about venous stroke. This is a recording of the lecture portion of the webinar that took place on the 30th of November. So our aims and objectives, a quick reminder of the venous anatomy, going over protocols for CT and MR venograms, some pitfalls in the interpretation of those studies, looking at clinical features and 5 example cases to illustrate the findings that we might see in neonates, in children and in adults with venous stroke. And looking at some of the potential treatment options: anticoagulation, endovascular treatment, and when the patient's in real trouble, neurosurgical treatment. So a little reminder of the venous anatomy, you all know this. We have the superior sagittal sinus, the inferior sagittal sinus, which is only just visible on this MR venogram, the internal cerebral veins forming part of the deep venous system, draining into the vein of Galen, which drains into the straight sinus. Those venous sinuses drain to the torcula, which is a point of communication between the deep and superficial systems. Then we have drainage via the transverse sinuses and the sigmoid sinuses into the jugular veins, back into the neck. So dural venous sinuses, it's important to remember that they are valveless venous channels that are in between the dural layers, and because they're valveless, it is possible to have reversal of the normal flow. And normally they drain towards the internal jugular veins. We've got a superficial venous system, and most of the veins involved in this are unnamed cortical veins. There are some large named veins, some of which are anastomotic. So we have the superficial middle cerebral vein, the Sylvian vein. We have the superior anastomotic vein, which is Trollard. And we have the inferior anastomotic vein, which is Labbe. We're not going to go into too much detail on those today because actually the anatomy is quite variable. They may be missing on one side or the other. And the venous territories that they drain can be quite variable as well. So it can be quite difficult to interpret. And then we have the deep venous system. So we have medullary veins collecting venous blood from the parenchyma, draining to the subependymal veins, going towards the internal cerebral veins, and ultimately to the torcula. We also have the basal veins of Rosenthal, which are located around the ambient cisterns, sort of following the course of the posterior cerebral arteries. Don't forget about the cavernous and petrosal sinuses. These are places where venous thrombus can quite often be easily overlooked. So the same way that we have arterial territories that you look for in acute ischemic stroke, we also have venous territories, and Radiopedia has a fantastic scrollable set of images which allows you to look through the typical territories drained by some of these veins. So, if you're looking at a hemorrhagic infarct that it's involving the cerebral convexity, then that might be a cortical vein thrombus or a superior sagittal sinus thrombosis. If you're looking at a lesion that's involving the thalamus and basal ganglia, might be a lesion that's involving the internal cerebral veins or straight sinus thrombus. So we looked at the images during the webinar for patient 1, who was an adult with thunderclap headache. So here's a selected image from the CT venogram. So what do we see? We see sulcal subarachnoid hemorrhage, high density filling in that sulcus. And you might suspect a venous thrombus, as we said, of a cortical vein, or maybe the superior sagittal sinus. But there are other causes of sulcal subarachnoid hemorrhage to bear in mind. Could it be an AVM or a juval AV fistula in this region? An aneurysm? Well, it's probably a more unusual type of aneurysm to occur this far away from the basal cisterns, so something like a macotic aneurysm. Amyloid angiopathy, if you had lobar hemorrhage elsewhere, or microbleeds. or RCVS, where the patient's maybe presented with a thunderclap headache. In this case, we saw the classical empty delta sign. So there's a filling defect on the CT venogram in the region of the superior sagittal sinus. If there's superior sagittal sinus thrombosis, that means we have increased venous pressure, and in this case causing the sulcal subarachnoid hemorrhage. So CT venogram, we're usually going to start in most centres with a non-contrast CT head. That's to help with the interpretation of what you see. And then the CT venogram is done supine with the patient's hands by their side, administering 75 to 100 mils of contrast and acquiring the scan around about 45 seconds. Timing's important because you want the contrast density to be highest in the venous sinuses and not in the arteries or the parenchyma. And to help with interpretation, you could make reconstructions, you could try and do subtraction images, volume rendering or something like that. But really a non-contrast CT head and the CT venogram together are going to be enough in most cases. But of course, every study that we do comes with some pitfalls. And my first CT pitfall is dense vessels. Not one dense vessel, but where all the vessels are dense. That can occur in people with a high hematocrit. So you have lots of iron in the blood because you have lots of red cells. And so this increases the density of the blood on CT. So that's newborns or infants, patients with polycythemia, severe dehydration, situations like that. To decide whether one particular vessel is abnormally dense, you could compare with other vessels. So if you're looking for an arterial thrombus, compare with the venous sinuses. If you're looking for venous sinus thrombosis, compare with the arteries and check the difference in density between them. We can also look at the venous sinus morphology. So in this case on the left, where you see the CT venogram, the superior sagittal sinus is a bit dense, but it's quite a young patient. The vein isn't expanded, so it's got a nice triangular shape, and sometimes that might be with straight or slightly concave walls. What we're looking for in venous sinus thrombus is a big blown out venous sinus with convex walls. Pitfall 2, arachnoid granulations. So arachnoid granulations are going to cause filling defects on the CT venogram, and this is really why a lot of people will choose to acquire a non-contrast CT head as well, unless you have one from before to compare. So in this CT venographic study, we see a filling defect in the left transverse sinus. You might interpret that as a venous thrombus. But if we look at the non-contrast CT head, you can see in that location that actually this lesion is hypodense. In fact, it's CSF density. And arachnoid granulations are usually going to be quite rounded or lobulated, kind of gently protruding into the lumen of the venous sinus. They'll be hypodense on the non-contrast CT. And crucially, again, the morphology of the venous sinus shouldn't really be altered, so it shouldn't be expanded. Pitfall number 3, variant anatomy. So most people, or often, you'll see one transverse sinus that is dominant, it's larger than the other one. But it can be difficult to decide, particularly in an MR venogram, whether a very small vessel could be partially thrombosed or whether it's kind of developmentally hypoplastic. So one trick to try and work that out is to look at the size of the groove in the skull. So here we've got another CT venogram image, where on the right side we've got a very large transverse sinus, which I think is dominant because the size of the sigmoid groove here is a really large kind of excavation out of the skull. On the other side, there's a very thin and almost discontinuous transverse sinus, but actually the groove in the bone is much smaller in this side, telling us that the right transverse sinus is probably just the dominant one and most drainage is happening via the right-hand side. There's other anatomical variants to be aware of as well. I wish I knew this one when I started off as a fellow. So in this case, we see a lack of contrast filling in the CT venogram in the anterior third of the superior sagittal sinus. If you looked at the non-contrast CT in this case, you'd see that there was no hyperdensity here and no vessel expansion because the sinus is deficient. And actually that's a developmental variant that's relatively common once you start looking for it. So for this one, you can check whether there really is hyperdense thrombus in this location on the non-contrast CT. And my last pitfall is the pseudo-empty delta sign. So here's an image from a child who's presented with a headache and a fever. On the contrast-enhanced CT venogram on the right, we see normal contrast filling of the transverse and sigmoid sinuses. On the left, we see what looks like a filling defect. We look at the bone windows, there's lots of fluid in the mastoid air cells, and actually on the bony reconstructions, there's some bone destruction there. So this looks like a mastoiditis, which of course is something that's associated with venous thrombus. But let's go back and look at the unenhanced CT head, where we see hypodensity in this region. In fact, anterior to the temporal bone, you can also see hypodensity. In fact, this is something extrinsic that's compressing the venous sinus, in this case, a subdural empyema. But again, it's important to be aware of, the fact that lack of filling does not always mean thrombus, and use all the information you have to try and come to a decision on whether there really is a venous sinus thrombus. For MR protocols, well, it's not just an MR venogram that I want to see when I'm trying to assess for venous sinus thrombus. So standard sequences help. You could look at the T1 sequence. You might actually see thrombus within the vessel, which might be T1 bright, or you might see hemorrhage in the parenchyma as a result of that. On T2, you might see a loss of the normal flow void, but sometimes you can see that with turbulent or slow flow as well. So that's one pitfall interpretation for MRI that we'll discuss later. We can look at the flare. Is there any parenchymal edema as a result of venous hypertension, or do we see a venous infarct? DWI sequence may help you see the thrombus as well. This diffusion signal can be abnormal. That might be because there is true restricted diffusion in the thrombus, but it might also be because there's some susceptibility in the thrombus if it's a little bit older. But also using the DWI sequence and the ADC map to assess for any venous infarct. We can also use gradient echo or susceptibility weighted imaging to look for hemorrhage or look for the clot, where we'll see blooming if there is thrombus. As far as venography goes, there's a few different techniques you can use. We could look at a time of flight venogram, we could look at contrast enhanced T1 images, or we could do a phase contrast study. To go through those, so a time of flight MR venogram, this is looking at flow signal, and obviously has the advantage that we don't need to cannulate the patient and give contrast, and that's really quite a big advantage in children. But it comes with one important pitfall, which is that something that is T1 bright will often be bright on your time of flight study. And that's going to be a real problem with interpretation of acute thrombus in the venous sinuses. We could do a contrast-enhanced MR venogram using a T1 weighted sequence. Here we are giving contrast, we've got a good signal to noise ratio, but again, if the thrombus is bright on T1, it's also going to be bright in the post-contrast study, and that could be a pitfall with interpretation there. So many places will use the phase contrast MR venogram, which can give you some beautiful 3D images that you can reformat. So we apply two opposite gradients to kind of null out the signal from anything that's stationary, and any moving spins will give us signal. And again, this involves no contrast and shows us flow signal. The real advantage here is that it's not susceptible to these effects from anything that is T1 bright, so it's really just showing us the flow in the vessels. But we do have to select the range of velocities that we're interested in, similar to a CSF study or something like that. So we might choose, say, 40 to 70 centimeter seconds for an arterial study, or we might choose about 10 to 20 centimeter seconds for a venous study. But if anything that falls outside that range might not give us the signal we're expecting. So again, just to reinforce that on the MRI, you're using all the sequences available to try and decide whether there really is a thrombus. So we're going to move on to specific scenarios. And the first scenario we looked at was perinatal venous stroke. So the risk factors for venous stroke are common across the age groups. And you remember Virchow's triad of stasis of blood flow, endothelial injury, hypercoagulability. And most patients who have one risk factor for venous thrombus and therefore venous stroke have more than one risk factor. So that could be trauma or surgery, infection like sepsis, severe dehydration in the unwell patient, malignancy, which is causing a prothrombotic state, some drugs, and in that you could include the oral contraceptive pill, for example, and hormones, particularly with reference to pregnant patients. There is also plenty of inherited thrombophilias that might predispose the patient to both arterial and venous stroke. So, what does venous stroke look like in a neonate? Well, venous thrombosis has an incidence of about 10 per 100,000 term newborns per year. The symptoms can be quite variable, sometimes seizure, sometimes reduced conscious level, sometimes a focal neurological deficit is noticed. And most often involving the straight sinus or the superior sagittal sinus in a neonate. In terms of venous stroke, intraventricular hemorrhage or parenchymal hemorrhage is actually quite common in preterm and term cerebral venous sinus thrombosis. And the damage that comes from venous stroke can be associated with problems further down the line, delayed myelination, parenchymal damage from ischemia or hemorrhage. And there's a little bit of a difference in maybe what you see on perinatal MRI depending on whether the baby is preterm or full term. So in preterm infants, we can see more often severe white matter lesions or intraventricular hemorrhage. In full-term infants, intraventricular hemorrhage is still very common, but maybe more often see unilateral thalamic hemorrhage or punctate white matter lesions, sometimes abbreviated to PWMLs. You'll see that in the literature. And the fact that neonates have an open fontanelle provides us with a really easy screening assessment if we are doing transcranial ultrasound anyway, to switch on the Doppler and demonstrate the flow in this image on the left in the superior sagittal sinus, and in this image on the right in the vein of Galen. And obviously we can assess the direction of flow as well, remembering that the dural venous sinuses are valveless and you could have reversal of flow. So patient 2 that we looked at was a term neonate with seizures. On the MR images, there was a little bit of hemorrhage near the caudothalamic groove, so potentially a mimic of germinal matrix hemorrhage, although this is a term infant. We also saw these linear branching hypointensities on T2 representing thrombus within the draining medullary veins. So this is the kind of the deep equivalent of cortical vein thrombus. And you might see two distinct patterns in an neonate and T2 weighted images, so those linear or radial hypointense lesions with or without cysts. And sequences that are sensitive to blood might really help to kind of highlight those branching patterns and make the diagnosis. Next, we move on to children. So clinical features in children are going to vary by the age of the child. So in preschool children, venous stroke's often associated with head and neck infection, causing lots of inflammation and generating a thrombotic state. So we think of head and neck infections like sinusitis, otitis media, mastoiditis, sepsis, meningitis, something like that. And obviously the symptoms can be quite variable, particularly if the child is not able to express exactly what's wrong with them. They could be drowsy or have a headache or present with a focal neurological deficit that's not immediately recognised. In school-age children, we may think more about some chronic illnesses as well as head and neck infections. So things like inherited thrombophilias, hematological malignancy, leukemia and lymphoma, And chronic diseases where there's an inflammatory component as well, like inflammatory bowel disease that's not well controlled. So these are risk factors for venous stroke. And children who are a bit older may have symptoms very similar to adults. So patient 3 we looked at was a school-aged child with a kind of stepwise neurological deterioration. And this was actually a case of homocystinuria, where the child had had recurrent venous thrombus. So in this case, you can see on the unenhanced CT here, chronic thrombus within the transverse sinus and the torcula. This is really calcified and really grossly expanded that venous sinus. And within the parenchyma, we saw focal infarcts in a kind of bithalamic or parasagittal distribution. We saw quite a low white matter volume, giving us quite large ventricles, unexpected for the patient's age, and also lots of dystrophic calcification. So homocystinuria, just to use as an example of an inherited thrombophilia, is autosomal recessive. There's deficient metabolism of homocysteine, and that homocysteine binds to the endothelium. Hopefully it's picked up on the heel prick test, because the patient's plasma homocysteine level will be high. And what we're looking for in brain imaging is multiple infarcts, chronic venous sinus thrombosis or recurrent venous sinus thrombosis with white matter signal abnormality. And remember, it's one of these conditions that can give you lens dislocation as well. And the lens dislocates the opposite way to Marfan's disease as a kind of distinguishing feature. So chronic venous thrombus gives us chronic venous hypertension. And we know from other tissues, like the leg, that you can see tissue edema due to venous hypertension. We could see thrombus that's calcified if it's chronic. We could see atrophic changes in the parenchyma, like white matter volume loss, and dystrophic changes in the parenchyma, like calcifications where there's been necrosis. Patient 4 that we looked at was another school-aged child, this time with a sudden onset of neurological deficit. So this was a case of hemorrhagic venous stroke. Here we see edema within the parenchyma. That also involved the cortex, not particularly on this image, but as you scroll through the scan. And at the time of presentation, on the first scan, there's parenchymal hemorrhage as well. There's also density in the superior sagittal sinus, giving us the diagnosis of a venous stroke secondary to superior sagittal sinus thrombosis. So characteristics of a venous stroke, clinically, you might find that the onset is preceded by severe headache, obviously, possibly fever, possibly a seizure at the time of onset, which are all unusual for arterial stroke in adults, but as a pitfall can be seen with arterial stroke in children. The deficit that the patient has might fluctuate a little bit as well, but these are not hard and fast distinguishing features. We really want the imaging to help us make the diagnosis. And what we're looking for in the radiology is an atypical infarct. So one that crosses venous territories between maybe the MCA and PCA territory, if it's an infarct in the territory of the vein of Labbé, for example. We could see disproportionate edema as a result of venous hypertension. And we're looking for hemorrhage at the time of onset. Hemorrhagic transformation of an arterial infarct often happens a little bit down the track, a day or two later, as opposed to being present on the initial scan. And then we're going to move on to talk about adult venous stroke. So clinical features of venous stroke in adults, incidence about 7 per million per year in adults. So in a centre like ours that has about 1.5 million population in its catchment area, probably seeing 1 a month or more. Symptoms: headache, seizure, papilledema, maybe a focal neurological deficit, but not necessarily, and maybe a fluctuating course, but not as a routine finding. And the territories that were involved, well, the thrombus is most often in the superior sagittal sinus, followed by the transverse sinus, followed by the deep venous system. We looked at patient 5. This was a young adult with a reduced GCS. So here on the axial T2 weighted images, it looks quite abnormal. There's abnormal T2 hyperintensity within the thalamus in the right in particular, but look very carefully, you also see abnormal signal in the corpus callosum, within the caudate and the lentiform. And then actually there's some more subtle change, but there is abnormal signal in the thalamus in the left at least. And on the phase contrast MR venogram, it can be very hard to see something that's missing. But in this case, the deep venous system has no flow within it. So there's no flow in the internal cerebral veins, vein of Galen, straight sinus. So immediately we could think that this is edema or infarction attributable to deep venous sinus thrombosis. Which leads us on to looking at pitfalls in MRI. And a really big one is abnormal signal from slow flow. So we're used to seeing flow voids on the T2 weighted images. And here's a coronal flare where there's some abnormal hyperintensity in the transverse sinus on the right. And here's an axial T2 weighted image where, even in a different plane, we still see some abnormal signal in that location. But this MRI was done for a patient with a colloid cyst. They had absolutely no symptoms at all. And this signal is generated from either turbulent or slow flow. And that's particularly a problem if you have one sinus that's non-dominant and perhaps has less flow than the contralateral side. So again, coming back to what we said about MRI, you really want to look across different sequences. If you have diffusion or if you have SWI, to try and work out whether this is artifact or whether this could genuinely be thrombus. And chronic thrombus can be a pitfall as well. I don't have a great case to show you, so here's a case from the literature where on the non-contrast T1 weighted image, there's kind of iso-intense signal within the transverse sinus. But on the susceptibility weighted image, we see a blooming artifact confirming that there's thrombus there. So chronic thrombus can have variable signal in T1 or T2 and sometimes can enhance with gadolinium as well. So one thing that might help here is to use our other sequences. In this case, the SWI helps make the diagnosis. But if we used phase contrast MR venography, we would see that there was no flow in that vessel. So we can kind of discount the possibility that that abnormal T1 signal is just due to slow or turbulent flow. Just one word on COVID-19 and venous stroke. We've all seen lots of COVID at different times of the year, depending on where you work. But it was described pretty early on from the patients in Wuhan that they had a high D-dimer and fibrinogen, antiphospholipid antibodies in some patients, and as well as thrombus in the deep veins of the leg and pulmonary embolus. These patients had arterial stroke, and in 1%, cerebral venous sinus thrombosis was reported, and that could be in multiple cortical veins with associated infarcts. So again, a case from the literature. Venous stroke or venous thrombus with COVID looks like any other venous thrombus, but on this non-contrast CT head just illustrating hyperdensity and expansion in the left transverse sinus. So finally, we're going to look at treatment options if we find a venous thrombus and guidelines on what we should do in those circumstances. So first of all, the European Stroke Organisation guidelines from 2017 say to use MRV or CTV to diagnose venous thrombus, and with acute venous thrombus, anticoagulation with low molecular weight heparin. The duration of therapy is not specified, and there's obviously lots of questions that you may come across in your stroke meetings about what to do if the patient does not recanalize. The only additional advice is that in women with cerebral venous sinus thrombosis to avoid estrogen-containing contraceptives and to consider low molecular weight heparin during any future pregnancies. The NICE stroke guidelines say even less, but they do advise full dose anticoagulation for venous thrombus or venous stroke unless there are comorbidities. But again, the duration of that therapy is not specified. The NICE COVID guidelines in 2020 also advise prophylactic low molecular weight heparin, for the prevention of venous thrombus, including in the head, in patients with confirmed co-infection. What if anticoagulation doesn't work? So large thrombi are unlikely to dissolve with parenteral anticoagulation alone. But recanalization is not really the aim of drugs. The drugs is to aim to prevent deterioration from propagation of the thrombus or to prevent recurrent events because the patient has a risk factor for thrombus. So we could consider intervention in patients who deteriorate neurologically despite therapy, who have hemorrhage on anticoagulants, or who might have a contraindication to anticoagulation like concurrent GI bleeding or something like that. We could consider two options, either catheter-directed thrombolysis or endovascular thrombectomy, a bit like stroke. Recanalization, however, is the aim of thrombectomy, but it's very difficult to know whether that really translates to a better outcome for the patient because any interventional procedure is going to carry risks with it as well. But in patients who have undergone catheter thrombolysis or thrombectomy for venous thrombus, it's a relatively low number of patients, but most have partial or complete resolution of the thrombus. And most have either no disability or only mild disability as their final neurological deficit at the time of follow-up. So it seems to be something that we can do pretty effectively and pretty safely. What we need to demonstrate is that it is more effective than alternative treatments. So here's a case courtesy of Fergus Robertson, who's one of my colleagues at the National Hospital but also works at Great Ormond Street. And this is a school-aged child who has a superior sagittal vein thrombus. On the coronal non-contrast CT head on the left, we see hyperdensity in the superior sagittal sinus. In the coronal CT venogram on the right, we see a filling defect that corresponds to that. And the patient proceeded to thrombectomy because they had a progressive neurological deficit. So here are the images with a guide catheter coming through the venous system, through the sigmoid and transverse sinus. We see an intermediate catheter going through the torcula into the superior sagittal sinus. Then a microcatheter and the dense access wire in the superior sagittal sinus. And then if I play the video, you can see that there's a balloon inflated and the catheter is withdrawn through the superior sagittal sinus while suction's being applied to try and aspirate the thrombus at the same time. Here's another case, again, a separate patient, but a school-aged child. If I play the catheter angiogram on the left, and you follow it through the phases, we see arterial, parenchymal, venous phase. And on the venous phase, we can see contrast going through the transverse and sigmoid sinuses and out through the jugular veins. But there's very little or no filling in the superior sagittal sinus here. If we look at the images from mechanical thrombectomy, this time using a stent that's deployed in the superior sagittal sinus, we can see that there's some recanalization of the vessel now that there wasn't before. So this, again, is a successful thrombectomy with recanalization, this time using a stentriever. And finally, if the patient is deteriorating despite that, why are they deteriorating? Well, usually brain herniation is the mode of death in patients that do not make it. That could be due to the parenchymal swelling from venous edema, or more likely a large infarct. It could be due to hemorrhage with massive ect and surrounding edema, or it could be if there's intraventricular hemorrhage or subarachnoid hemorrhage as a result of hydrocephalus where there's no shunt in place. There is some limited evidence from uncontrolled studies to support decompression, but it's really a last resort for the deteriorating patient. So here's a non-contrast CT head on the left showing you before decompression with a large venous infarct with hemorrhage, midline shift and effacement of the ventricles not long after the time of presentation. On the right, we see a decompressive hemicraniectomy And as with arterial stroke, the larger the hemicraniectomy, the more likely it is to be successful, where the right cerebral hemisphere is now herniating through the defect, but that has relieved some of the midline shift and mass effect on the ventricles. So, in summary, in the webinar, we looked at protocols. My personal preference is CT and CT venogram, but MRI and MR venogram's a perfectly reasonable alternative to make the diagnosis of venous stroke or venous sinus thrombosis. We talked through pitfalls like anatomical variants, the different MRV sequences we might use, and then the advantages and drawbacks of those, and flow artifacts in MRI that can sometimes fool us. We talked about potential procedures that might help, so that could be thrombectomy for your deteriorating patient, or those in whom anticoagulation is contraindicated, and decompression for the patient with brain herniation as a life-saving procedure. And we talked about different age groups. Neonates, where seizures might be common at the time of presentation. Remember the case we looked at of medullary vein thrombosis, as well as the deep venous sinus thrombosis. And remember the long-term effects with white matter volume loss or delayed myelination as a result of an extensive venous sinus thrombus. In children, we talked about risk factors like sepsis or long-term conditions or inflammatory conditions. Children might have symptoms similar to adults, but it's something that can often be overlooked and present in unusual ways. So venous sinus thrombus and venous stroke is something to think of in the child presenting with a neurological deficit. The next session in this series is going to be imaging and reduced consciousness on the 7th of December. That's it for this session. Thanks for watching.